Then second important thing is that PTU and methimazole both are teratogenic, but methimazole, the complications or the adverse effects or the complications in the child or the fetus, they are much more with methimazole as compared to PTU. The adverse effects are much more in methimazole as compared to PTU. So the teratogenicity I'm talking about. So historically, what was there, that PTU was the standard drug. It used to be given in pregnancy, but later they found that PTU causes hepatotoxicity, which can cause even liver failure and can lead to the situation where transplantation is supposed to be done. So PTU is not given in pregnancy except in the first trimester, because in the first trimester, why we give PTU? Because the adverse effects or the congenital anomalies with methimazole are much higher as compared to PTU. So propylthiouracil is given in the first trimester, and most of the organogenesis, it is almost complete. Most of the organogenesis, it is completed in the first trimester. So in the second trimester, somewhere between 14 to 16 weeks, shift from PTU to methimazole. Now there is a difference. PTU has a shorter half-life, so it is given in divided doses, generally thrice a day, 100 to 300 mg, 3 times daily we give. But on the other hand, methimazole is once daily, and the dosage is 5 to 15 milligrams. Now, when you are giving a dose which is thrice daily and 100 to 300 mg, now suddenly you have to shift to a dose which is once daily, and that to 5 to 15 milligram daily. So how will you convert? So the initial conversion factor is a ratio of 1 to 20 of methimazole to propylthiouracil. That means 1 to 20 ratio means wherein 1 is methimazole and 20 is propylthiouracil. So if you are giving 5 mg of methimazole, so you will give 100 mg of propylthiouracil. So this is the initial conversion factor. Second thing is that every drug, as we know, they have side effects. So rashes, pruritus, or fever, nausea, such are the side effects of these drugs. Nothing very severe or serious. Another thing what important I want to highlight is that see, if you encounter a patient wherein thyroidectomy has been done or radioactive ablation has been taken, or she was treated earlier, in that case please look for traps, because I told you they may persist and they will cross the placenta, and that will cause a fetal hyperthyroidism. So in that case, how will you manage the case? There's something called block and replace strategy. Now, what is this block and replace strategy? Block and replace strategy is that you will give antithyroid drugs to the mother, but simultaneously you will treat her with levothyroxine, just to maintain a euthyroid status in the mother, and at the same time you are treating the fetus for hyperthyroidism. So that is called block and replace strategy. So that you have to give. Then if at all you find that you are giving ATDs and hypothyroidism is not getting controlled, or the patient is highly non-compliant, or patient is allergic to antithyroid drugs, wherever it is necessary, if surgery is to be done in pregnancy, that we will do in the second trimester, as we do in the other cases. That is the safest period of pregnancy. In case the symptoms of hyperthyroidism are quite disturbing to the patient, or they're not getting controlled right now, so in that case beta blockers, that is propranolol, or such beta blockers you can give, but please give them for a very short while, because they have their own complications. They might cause IUGR, they might cause fetal bradycardia or neonatal hypoglycemia. So beta blockers, if they are given for a short period of time. So this is all. And one more important point I would like to highlight here is that TSH receptor antibodies, as soon as the patient comes, you will check then, and secondly you will check them between 18 to 22 weeks, and the third time you will check them between 30 to 34 weeks. That is a standard recommendation. So please check traps at least thrice in one pregnancy. So that's all for now. Thank you so much.